So where are you from, Dr. Nasreena?
I'm from Kerala.
Okay.
Um, right now, I am in UK.
So let's start with this case, Vignet. I hope you've gone through the case. I had
Yes,
already projected
yes,
it.
yes,
So what do you
yes.
think the problems that this patient is having? What are your differential diagnosis and how do you interpret these lab findings here?
So, patient is having hypoxemic respiratory failure, probably a pulmonary embolism, aortic dissection, or a pulmonary edema. Also, there is a shock, which is most probably hypovolemic, secondary to hemorrhagic shock, and a cardiogenic shock also. Then there is coagulopathy, thrombocytopenia, hypofibrinogenemia, and increased D dimer, suggestive of coagulopathy, probably due to DIC, secondary to hemorrhage. And there is AKI with anuria, hyperkalemia, and high anion gap metabolic acidosis. Mm, and there is also right lower limb pain, which could be a DVT, cellulitis, or a right lower limb ischemia.
Okay, great, great. So, so this is the X-ray chest that was taken up, and these are the ECG findings.
Okay.
So, how do you interpret these X-rays and ECGs?
So the X-ray is showing widened mediastinum with loss of with blunting of the left costophrenic angle, probably a effusion, could be a hemorrhagic effusion, and widened mediastinum could support could be a feature of aortic dissection, and the ECG is showing ST elevation in lead 2, 3 AVF with ST depression in 1 AVL, one AVL, V1, V2 as well.
So, what does that indicate?
This could be a inferior wall MI with reciprocal changes in the lateral leads, 1 AVL. Yeah.
Okay.
Mm.
So, is this myocardial infarction or something else? How do you proceed diagnosing this case?
Okay, so I will be first of all, management wise, airway breathing circulation disability and exposure approach and stabilization. Here, patient's airway is patent. Breathing his tachypneic on oxygen supplementation. But for the circulation, patient is for the airway, I might closely monitor and have to consider mechanical ventilation because patient is having hypotension, hypoxia with multi-organ involvement. Circulation, I will resuscitate with the blood and blood products considering he's in hemorrhagic shock, as well as I will correct the acidosis, coagulopathy, and the hypothermia. And also I will monitor closely the urine output, and I will initiate on anti-hyperkalemic measures. If patient is refractory to anti-hyperkalemic measures, then I will have to consider renal replacement therapy. I will involve a cardiothoracic surgeon, and nephrology consult will also be taken, and I will require a 2D echo, a CT iotogram, which would not be possible considering his hemodynamic instability. I will also request for a rotum or TEG for the cause for the bleeding. These are the things.
Okay. So, would you like to do a 2D echo? Would you be able
Yeah,
to find out certain
yeah,
findings with the 2D echo also?
yeah. I asked for a 2D echo.
So, what sort of findings you are expecting?
2D echo one, I want to look for any regional wall motion abnormality, considering the ECG changes to look for any acute myocardial infarction. I will also look for a RARV dilatation to look for any pulmonary embolism feature. And also, I will look for any pericardial effusion if I am suspecting um, aortic dissection causing pericardial effusion, and also look for any aortic valve valvular problem if the dissection involves the aortic root. Mm, yeah, these are the things.
Okay. So, which all pathologies, I mean, these are the differential diagnosis that you told me. Which all other pathologies that you would be looking at the CT when you do it?
CT angiogram. CT angiogram, I want to look for the aortic dissection level. In the CT, I will look for the lung parenchyma involvement, pulmonary edema feature, and also if pulmonary embolism, to look for any pulmonary embolism.
Okay. Any other, investigation that you would like to do, considering
Mm,
these X-ray findings, CT findings, and the ECGs?
CT angiogram or a
What do you expect in CT angiography?
angiogram, I will look for the dissection level. If it is involving the ascending arch of the aorta, the root is involved, or the descending aorta, and look for any hemothorax or a pericardial effusion. Won't be, yeah.
Would you like to classify that aortic dissection?
According to the Stanford, we have type A, type B. Type A is anything involving the ascending aorta before the origin of the left subclavian artery, and type B is below the origin of the left subclavian artery. It can be the Baker classification is also there. Type 1, type 2, type 3.
Yeah. So this patient was unstable, and we tried to resuscitate a patient with fluids and analgesics, and there was no significant improvement even after fluid resuscitation and vasopressor support. His condition did not improve. Rather, he became drowsy and hypoxemic. He had to be intubated and put on mechanical ventilator because his respiratory parameters were worsening all throughout. His hourly urine output was also continuously low in spite
Okay.
of large fluid boluses. A noradrenaline infusion was started, but in spite of that, there was sustained hypotension.
Okay.
And CVTS team was asked to review the patient after an echocardiography.
Okay.
Okay, echocardiography showed acute aortic dissection involving thoracic aorta and need for urgent surgical intervention. This was the CT scan which was done, and this
Okay.
is the 2D echo. What abnormality do you see in the CT scan and the echo?
Echo is showing a regurgitant jet is seen across the aortic valve, and the CT is showing a false contrast in the contrast, which is differentiating both true lumen and false lumen in the descending part of the aorta.
Okay. So, in addition to the vascular pathology, what does the CT scan shows apart from vascular pathology? Do you see anything extra? You said dissection you could see. Any other appropriate finding that you did you notice in this CT?
Can I see the CT once?
Yeah.
There is a fluid around the heart. Probably a pericardial effusion also is present.
Yeah, that's fantastic. So how do you explain the severe multiple organ failure syndrome in this patient?
So if it is a it is a aortic dissection in which is creating a false lumen. So that can involve the aortic root causing aortic regurgitation. It can also dissect. Massive hemorrhage can occur into the false lumen and can lead to hemothorax, pericardial effusion, and hemorrhagic shock. It can dissect the artery supplying the brain, causing ischemic stroke and hypoperfusion of various organs like kidney, leading to AKI and other organs, mesenteric ischemia, hypoperfusion of the liver, causing um, hepatic dysfunction of extremities, causing ischemia. These are the
Okay, fantastic. So this patient underwent thoracotomy and aortic dissection and aortic root hematoma was identified. And in addition to that, there was right coronary artery dissection and there was blood oozing into the pericardial space. Patient underwent replacement of both the ascending aorta and the aortic valve. Following oversieving of the proximal right coronary at the site of dissection, and then the bypass grafting with the saphenous venous graft was done. This patient was shifted to the ICU, sedated, paralyzed, and mechanical ventilation was also done
okay.
after the surgery.
Okay.
And the postoperative period in the ITU was very stormy for next 24 hours. This patient was on high vasopressor inotropes. And this patient also had short runs of pulseless VT, which was
Okay.
reverted with defibrillation. His hourly urine output reduced further, and the urine output was very high colored as well. His right leg was swollen, and there was blackening, and the blisters were also seen.
Okay.
So, what do you want to do? What is your probable differential diagnosis here? And how will you treat this patient?
Should I read this lab investigation now and then
Yeah,
answer?
you can read. Yeah, please.
Yeah. Okay, so now the patient is having there is blackish discoloration with blisters of his right leg, suggestive of a cellulitis or probable necrotizing fasciitis, as well as the lab parameters are showing leukocytosis with worsening of his acute kidney injury from the previous value, with worsening hyperkalemia and hyperphosphatemia and hypocalcemia, with elevated CPK level favoring rhabdomyolysis, and the ABG is suggestive of high anion gap metabolic acidosis with partial respiratory compensation, which is also worsening compared to the previous ECG, ABG. So patient is moving into septic shock secondary to necrotizing fasciitis involving the multi-organ system. I will start him on, I will again go by ABCD, and I will start him on broad spectrum antibiotics, covering the adding clindamycin as an antitoxin with vancomycin, and I will also consider starting him on vasopressors and maintain the map around 65 mmHg, and adequate hydration is required for the rhabdomyolysis. But I will again assess his fluid responsiveness as per the dynamic indices. If he is going into fluid overload state with refractory hyperkalemia, I will have to consider renal replacement therapy. Mm,
Okay. Any other differential diagnosis that you can think about apart from necrotizing fasciitis or any other thing? What do you think? What do you think would be the most probable positive factor?
deep vein thrombosis, peripheral vascular disease, cellulitis, necrotizing fasciitis. Um, and I will also get a arteriovenous Doppler or a CT angiogram of the right lower limb.
Considering his aortic dissection, do you think any other possibility could have led to this situation?
He had a graft done, so it could be graft mm, or ischemia due to the dissection. Mm,
Mhm.
or a embolic phenomenon happened.
How do you diagnose embolic phenomena will lead to what?
Um,
So, what is the ultimate outcome of this cellulitis?
if it is necrotizing fasciitis, mortality is high. Um,
So, what will you do to treat this?
so we need a surgical consultation, a fasciotomy, a wound
You would
debridement,
like to
and
do surgery for these patients immediately, or you would like to wait, or any alarming sign that
yeah,
you consider?
there are signs of compartment syndrome because there is rise in CPK, which are suggestive of rhabdomyolysis with worsening acute kidney injury and acidosis. So I will get a urgent surgery consult for debridement and fasciotomy.
When do you call it as compartment syndrome?
We will measure the we will have to measure the delta pressure and the compartmental pressure. If the delta pressure is more than 30 mercury, it is more in favor of, or we will get features of pulselessness, paresthesia, severe pain, um, pain, pallor. These are the clinical features.
Okay. So, how do you proceed as far as the treatment of rhabdomyolysis is concerned? How will you treat?
Uh, Ideally hydration is the treatment initially, but if my patient is already in fluid overload with fluid overload and there is refractory hyperkalemia, then I will have to consider optimization of the fluid status by removal. In this case, CVV, continuous veno-venous hemodiafiltration, would be the ideal choice. I will also start him on broad spectrum antibiotics along with clindamycin to as an antitoxin. And
Why do you think Clostridial infection would be a possible causative factor here? Does he
so,
have why do
sorry,
you think Clostridial infection would be a possible organism causing necrotizing fasciitis? This patient doesn't have history of trauma. Do you still
yeah,
feel that this could be a necrotizing fasciitis?
uh, it's no, I just yeah, trauma is not there. Usually, it happens in the immunocompromised. Um, it could be a graft infection because he had a graft done. Mm,
If there was no grafting done in the leg.
then it could be a, DVT or a heparin-induced thrombocytopenia causing lower limb edema followed by cellulitis. That could be a possibility. Mm,
Okay, so how will you treat this rhabdomyolysis? You said
CRT would be.
CRRT. So how would you prescribe the CRRT?
Ideal dose would be 20 to 25 ml per kg per hour. But to achieve that dose, we need to prescribe a higher dose, around 25 to 30 ml per kg per hour. And I will be starting him on continuous veno-venous hemodiafiltration mode. In that blood flow, I will keep around 150 ml per minute, and I will add echo, and then I will choose a anticoagulation for him. Since the patient is having thrombocytopenia coagulopathy, I would consider regional citrate anticoagulation. This will be my setting, and a pre-dilution and a post replacement, pre-replacement and post-replacement fluid will also be added.
So what will be your setting for a pre-pump and post-pump?
So if I'm taking 30 ml per kg, half of it will be chosen for the dialysate fluid. The rest half I will divide 1/3 for the pre and 2/3 for the post replacement fluid.
You would like to keep the dialysate little higher here?
Dialysate rate, yeah, I will keep it high because there is dialysate rate. I'm not sure.
Okay. Okay, so this patient was reviewed with a surgical team, and their opinion was like compartment syndrome of the right leg,
Okay.
and urgent surgery was advised.
Okay.
Patient underwent bony amputation.
Okay.
Considering severe vascular damage of the affected leg, and patient was shifted back to the ITU again,
Okay.
sedated and mechanical ventilated. But there was persistently increased requirement of noradrenaline, and it was higher than the pre-op values. His peak airway pressure started increasing from 30 centimeters to 45 centimeters of water, and the plateau pressure rose from 27 to 35 centimeters of water. And his tidal volume was 8 ml per kg, respiratory rate was 29 per minute, and his arterial PCO2 was 52, PO2 was 64 millimeters of mercury, and FiO2 was 70%. And the PEEP requirement was 10 centimeters of water. His mean arterial pressure was 68 millimeters of mercury, and he was anuric completely. What do you think is the clinical condition at this point of time now?
So now the patient is having worsening hypoxia with increase in the peak pressures and the plateau pressure. So I will be thinking of pulmonary edema, or he's progressing into a acute respiratory distress syndrome. These are the possibilities. And also I will have to sir, only the differential diagnosis I have to mention.
Yeah.
So
you tell us about the differential diagnosis.
So the major findings are increase in the peak pressures, plateau pressures, and he's also going into higher type 2 respiratory failure with increase in the FiO2 requirement as well. So I'm thinking of fluid overload or a ventilator associated pneumonia.
Okay. Do you think it is ventilator associated lung injury or something else?
For ventilator associated pneumonia, patient has to be on the ventilator for more than 48 hours. Or if he's not fitting into that criteria, we will also look for other features as well, like increase in the tracheal secretion, increase in the total count. If there are no other features, then more in favor of pulmonary edema, or it could, or a, yeah.
Do you think it is VAP or any other clinical condition? Why not VAC and IVAC or
yeah,
VAT?
yeah, it could be, yeah, in.
How will you differentiate these three clinical conditions?
Infection, ventilator associated event happens in a is also a possibility if there is an increase in FiO2 or increase in the PEEP. by 2 centimeter. Mm, if there are no features of infection like increase in the tracheal secretion or change in the color of secretion or increase in leukocyte count or a chest x-ray not showing any features of infiltrate, it's mostly a ventilator associated event. If there are features of infection, then we will have to send sputum analysis by a bronchoalveolar lavage. If the bronchoalveolar lavage is gram stain is showing organism, it is a VAP. It is considered as VAP.
Okay. So you would like to do any invasive, non-invasive diagnostic test to diagnose this clinical condition?
Uh, like now, I have to answer what are the immediate
So
measures.
this is the X-ray finding of this patient. So what will it?
So the X-ray is showing a homogeneous opacity involving the left lower lobe, probably a consolidation with underlying effusion, and there are bilateral infiltrates as well. So I will get a bronchoalveolar lavage done, sending gram stain culture, and I will also get a CT scan of the thorax done if possible, if patient is stable. And if by reducing the tidal volume um, and optimizing the PEEP, if the FiO2 is still high, then I will go for recruitment maneuvers as the patient is progressing to severe ARDS.
So which recruitment maneuver would you recommend in this patient?
Recruitment maneuvers and rescue maneuvers. Recruitment maneuvers are not, um, as per the evidence, it is not recommended. Rescue maneuvers, I will go for non-ventilator strategies like sedation and paralysis as per the accuracies trial. If still no improvement, then I will go for prone ventilation for 16 hours. Even after this, if there is no improvement, then I have to consider extracorporeal membrane oxygenation.
Okay. You would like to go for prone positioning?
Yeah, if even after sedation and paralysis, if the patient's PF ratio is below 150 mmHg after optimizing the PEEP, then I will have to go for prone ventilation.
Prone is feasible in this patient?
Mm,
Do you think proning will be possible here?
prone because yeah, he has undergone a sternotomy, thoracotomy. Mm. The absolute contraindications are cervical unstable injury.
Okay. You would like to go for high frequency oscillatory ventilation?
No, as per the Oscillate and Oscar trial, there is no recommendation for HFOV.
Okay. What is your fluid strategy in this patient?
I will go for a conservative fluid strategy, maintaining negative balance.
Any trials on fluid therapy? Why?
Fact trial.
Okay. Anything else?
Mm, no, I don't know.
So what are the different fluid strategies that you advocate in your ICU?
Fluid is optimized as per the dynamic indices. Here in this patient, I can go for since the patient is oliguric and anuric with worsening, I can optimize by CRRT.
Okay.
If the patient is stable with stable hemodynamics, I can go for diuresis.
What are the
Oh,
static and dynamic parameters of fluid responsiveness?
static parameters are CVP, global end diastolic volume, pulmonary capillary wedge pressure, pulmonary artery occlusive pressure, global end diastolic volume. The dynamic indices are pulse pressure variation, stroke volume variation, passive leg raise test, endo-expiratory occlusion test, IVC collapse distensibility index. These are the ones.
Okay. So what do you, what is your find, what abnormalities do you see in this X-ray? Do you see any
There,
abnormality or it is normal X-ray?
there are abnormal findings. There is a homogeneous opacity involving the left lower lobe. It could be a consolidation or a effusion because there is blunting of costophrenic angle as well. And there is bilateral infiltrates more in the hilar region, perihilar region.
So what would you do? You diagnose and treat. How will you diagnose and how will you treat?
I will send bronchoalveolar lavage sample to rule out any infection. If there is, I will also go for a lung ultrasound to look for any effusion. If there is effusion, I will send for diagnostic for diagnostic purpose. I will send the analysis, and also if it is compromising the ventilation, then I will go for um, thoracentesis, therapeutic thoracentesis.
Okay.
But if it is
So you want to do a bronchoscopy. So what is the sensitivity and specificity of bronchoscopy?
it's around 90%.
Okay. So if you grow any organisms, so this patient has grown Klebsiella in the bronchoalveolar lavage. Okay. And this is endium organism.
Mhm.
So how will you treat these patients' infection?
Um, First of all, if it's a bronchial sample, then I will look if the count is enough to interpret or if it is a contaminant. Um, if if the colony forming units are 10 raised to the power of 3, then I will consider it as an infection. And if it is a NDM organism, with the clinical context, if patient has worsening hypoxia secondary to this worsening hypoxia, then I will cover antibiotics for the NDM Klebsiella. I will also send the sample for carbapenem resistant species assay to look for
Okay.
which specific organism.
So if the organisms are NDM, so what is your possible antibiotic of choice?
NDM organism I will cover with Astrionam. Astrionam would be the ideal choice here.
Only astrinum?
Ampicillin sulbactam.
Penicillin sulbactam, is it a good choice for NDM organisms? What other options you have for NDM organisms?
Astrionam and or colistin. Colistin.
Good. How long you would like to continue these antibiotics?
Ideally 7 to 10 days, but if there is a empyema, then I will go for 14 days.
Okay, now will you decide about continuation of antibiotics?
I can go check the procalcitonin level and its trend. If it is a falling trend, if patient's hypoxia is improving, if the secretions is improving, then I will consider de-escalation and of antibiotic.
Okay. So this patient underwent ICD insertion on the left side and 800 ml of blood was drained. And there was marginal improvement in the ventilator parameters after that. Bedside percutaneous tracheostomy was also done for that patient. And over the next few days, the patient's clinical condition improved. Vasopressor requirement reduced and ventilator support was also reduced. This patient was weaned off from paralysis and sedation. However, the patient remained unresponsive even after a few days, and his clinical examination showed GCS of even M2VT with bilateral symmetrical pupils reacting to light. And bilateral plantar reflexes were unnoticeable.
Okay.
So, regarding the neurological status of this patient, what is your differential diagnosis?
Mm, One could be a metabolic problem, hyponatremia or hypoglycemia, or it could be a septic encephalopathy. It could be non-convulsive status, non-convulsive status epilepsy or convulsive epilepsy, stroke, hypoxic brain injury, or yeah, these are the possibilities. Stroke
Okay.
can be bleeding.
So, what will you do next to elucidate the neurological condition?
I will get a EEG done, a metabolic profile, sodium, glucose, ammonia level, and I will get a, CT brain or an MRI brain to look for the cause.
Okay. Any other investigations? How will you prognosticate these patients' outcome?
First of all, I will see if what is the cause for this neurological deterioration. If it is due to septic encephalopathy or metabolic factors, first of all, I will correct the cause and see for any improvement. And if it is a non-convulsive status epilepticus, then the prognosis is slightly patient might take a longer time for improvement. If MRI or CT brain is showing any anoxic brain injury, then prognosis may um, be bad. He might have a prolonged neurologic recovery.
So, this was the CT brain. Neurologist was also consulted, considering the poor neurological status. And the EEG was done. EEG did not show any epileptic electrical activity. But this was the CT. What do you think from the CT? What is your interpretation?
CT scan is showing there is atrophy of the brain.
Mhm.
But there is no evidence of any hemorrhage or ischemic stroke. Mm, There is shrinkage of the brain seen with
Okay.
clear. The sulci and gyri can be clearly seen.
You can see Salka and Gyra. Are you able to differentiate?
Mm,
Mhm. Okay. So, how will you explain the severely impaired cerebral status of your patient to the family?
So, if the CT brain is showing maybe features of anoxic brain injury, so if that is the cause, then first of all, it is too early to prognosticate. Maybe we can give some more time like around 40 to 72 hours to look for any improvement in his neurological condition. If during that time, if there is no improvement in his neurological condition, then there is high chance of um, the recovery can be prolonged.
So, as a family member, you have to explain it to me about further plan of action and the prognosis of this patient. I am one of the relative, and I'm really devastated to see the clinical outcome of the patient, and I'm not very happy with the ongoing treatment that the clinical team has offered. And you have to communicate with me for further management, and you should convince me that the treatment is probably the best that you can offer. How will you do that?
So first of all, I will involve a multidisciplinary team involving all the treating physician and the intensivist. And then first of all, I will make sure if all the family members are present there and the situation is good enough, and I will ask them if they have anyone else to be involved in this discussion. I will ask them to any other family members will be invited, important person, and then I will ask them how much they know about the patient's condition till now, what is their understanding. Once after knowing that, I will first of all tell them break the bad news that the patient is not progressing good in terms of his neurological condition. There is he has low GCS, and his CT brain are is suggestive of anoxic brain injury. We have supported him from the beginning. We have supported him with all the invasive organ support, including mechanical ventilation and renal replacement therapy. Despite all that, he deteriorated, and he's at present on all this with all this support, he's not having a good improvement in terms of his neurological recovery. So we will discuss with the family about the as a shared decision model. We will ask them if they want to continue the treatment further, because continuing could be futile for him. If there is since there is not much of response to the treatment and there is deterioration. If the family agrees with not continuing, then we can consider end of life care and withdrawal of life supporting therapies.
Okay, great. I think that was all from the long case perspective and discussion.
Okay.
All the best. We will have a debriefing session also later on.
Okay.
So, about what are the possible uh, inputs from my side.
Okay.
I will get back to you on 15th or 16th. The
Okay.
team will get back to you.
Okay.
And
Okay.
all the best for your Viva exams.
Okay, sir.
And my best wishes.
Thank you so
Good
much.
luck.
Sir, CBS won't be there, no, now?
Pardon?
CBS?
CBS?
CBS, or this is only CCS?
You will have to ask this question to the first academy.
Okay. Okay.
You want to
Okay.
know about your next Viva?
Yeah, because in the
Yeah.
sheet provided to me, it was
Hmm.
written CCS plus CBS.
Yeah, I think you will have to. Okay, Sushmita, can you please update the participants about the next exam that they have to go through? Sushmita ji, the team will update you.
Okay, I will ask them.
I hope you have the contact numbers.
Yeah.
Is
Okay.
it planned for today only?
I got a sheet with two candidates' name. In that, my name was also there, and it was mentioned that I have CCS and CBS. So I don't know if it is covered along with this.
No, this was CCS, both, covering post-operative care and
Okay.
renal replacement therapy and all that, and
Okay.
prognostication.
Okay,
I
sir.
think Sushmita will be able to get back to you.
Okay.
Hmm?
Okay, sir. Thank you.
Thank you. Thank you.
Okay, sir.